As you start your training, you will be taking care of terminally ill patients during your residency or fellowship. Doing this well is an important part of being a doctor. My advice is to use this time to develop your communication skills and practice and seek feedback during your training. It's what families remember about you and the care that you gave their loved one. Some common scenarios and tasks that you may do during your training include giving patients a poor diagnosis or breaking bad news, communicating prognosis to your patients and families, explaining complex medical information, clarifying goals of care for patients and families, talking to patients about advanced medical directives, negotiating code status, talking about dying, loss, and grief, and finally pronouncing death. Part of doing all of these things well is having a set of good communication skills. In the next few slides, we'll go over some specific strategies and a practical approach. In the early 90s, Robert Buckman and colleagues wrote about how to break bad news using a method called the SPIKES method. S is for setting up, P is for perception, I is for invitation or information, K is for knowledge, E is for emotion and empathy, and S is for summary. So in the first part of breaking bad news, setting up includes preparing the environment before you even go in to talk to the patient. Making sure that there are plenty of chairs, sitting down, making sure that the environment is quiet and without interruptions. The P is for perception. And in this step, it's very important to ask the patient, what do you understand about your disease? What do you understand about this hospitalization? What do you understand about your cancer? And ask the patient to tell you what they understand. And in this step, you may discover that the patient understands quite a bit about their disease. In this step, you may discover that the patient knows very little or has some misinformation about their disease. This is an important step to take during your breaking bad news conversation so you know where to start with the patient. And again, this is done with very open-ended questions. Tell me what you know. The next step, I, invitation, information, this is essentially asking the patient, what do you want to know? How would you like to receive the information? And some patients don't want to know much, but give us permission to talk to their family. Some patients want to know details, and some patients are more big picture patients. They want to know the big picture, but not details. This is a very important piece of information to know before you break the bad news so you know how to deliver it most effectively. The next step is K, the knowledge step. This is the actual breaking of the bad news. And so you'll notice that we've done 3 steps before you even break the bad news, and I can't emphasize how important that is to do those steps well. So in the K step, you're actually breaking the bad news and you're delivering a prognosis or a diagnosis. It's best to do this in layman's terms and making sure that you speak in a way that the patient and the family can understand. And the next step is the one that we tend to skip or go over very quickly. The E is the emotion and empathy step. And I think this is the hardest for physicians because we tend to rush into the following step, which is to try to figure out a plan of care. After you break the bad news, the best thing to do is just to be quiet and to allow some silence and to allow some time for the patient or the family to process the information that you've just told them, and to let the patients have whatever emotions that they have and to be able to acknowledge and validate those emotions. The patient may cry, the patient may get angry. There are a variety of emotions that may come after you break bad news to a patient or family, and it's okay for those patients to have those emotions. If you fly through this step and neglect to spend time on this step, it's hard for patients to go to the next step to make decisions. Oftentimes, patients and families do not feel heard and respected if the physician does not spend some time letting them talk and ask questions. Some nonverbal ways include eye contact with patients or families, and again, you have to take some cultural cues for this. Making sure you sit down, find a chair, and pull it up beside the patient. You never want to break bad news standing up and looking down at the patient. You want to make sure you face the patient and that you have open body posture. So not crossing your arms in front of your chest, not having a notebook close to your chest. Those are closed body positions. Making sure you have an open body posture, leaning towards the patient, and making sure that you are relaxed without tension. Touch can be very therapeutic in these conversations. Again, you have to take cultural cues. Usually a pat or a touch on the hand or the forearm is the least likely to be misinterpreted. But again, you have to take some cultural cues. Some verbal ways to express empathy. There's a helpful acronym that was described by Tony Bach and his colleagues, the NURSE acronym: naming, understanding, respecting, supporting, exploring. These are all helpful things to say when you want to express empathy in these difficult conversations. So N for naming. Naming the emotion that you're seeing from the patient and family can be very helpful and can help the patient feel validated and heard. So saying something like, "You seem upset," or "I see that you're crying. Tell me what's bothering you the most." You're naming the emotion, you're putting it on the table, and you're recognizing and validating it. Understanding. A statement of understanding can be very helpful. "I understand that this must be very hard since your father was doing so well last week." A statement of respect. And this is very important for families who have been longtime caregivers of ill patients. So saying a statement of respect, "I'm so impressed about how you've taken care of your mother all these years. You've done a really amazing job taking care of her." A statement of support. "Our team will be here for you and your family." Making sure that the patient and family do not feel abandoned in any way, shape, or form. Exploring. Tell me more. The final step is the S step, the summary step. This is the step where you're going to check to see how well the patient understood what you just told them. So I usually say something like, "I know we've talked about a lot of things. Tell me what you heard. Tell me what you understood." And that's when you check for understanding and create a time to give the patient a summary. There are times when patients just heard maybe 10% of what you just said. It's important to figure that out and spend some time going back and maybe answering questions and correcting misinformation. Now we're going to watch a video demonstrating how to break bad news using the spikes method.
Hi, Ms. Mays.
Hi, Dr. Harrington.
It's good to see you. I've got a medical student with me today. This is Elizabeth.
Hi, Elizabeth.
Is it okay if she stays with us?
Oh, that's fine.
Okay. So we're going to talk about your CAT scan results from yesterday.
Okay.
And talk about kind of where your cancer is and what's going on.
Okay.
Do you want any family to be present for our discussion, or are you okay by yourself?
I'm okay. I'm okay by myself, but my family is coming later today. Maybe you'll help me bring them up to date.
Absolutely. I'll be happy to meet with them as well.
Okay.
Okay. I'm going to get some things out of the way and pull up some chairs.
Okay.
So, Miss Mays, tell me what you understand about your cancer. What have the doctors told you already?
Well, I have breast cancer. It's stage 4. It's incurable, and we've been doing chemo and radiation to try to slow everything down. I don't know what my prognosis is, but I hope to have as much time as I can with my family. And I came in this time because I got nausea and was vomiting and had some weaknesses.
Okay. So sometimes when talking about test results and prognosis, I have some patients that want to know details, as much detail as possible, and I have others that really don't want to know anything, but give me permission to tell their family. And then some patients are somewhere in the middle. They just want to know kind of big picture, but not many details. What kind of patient do you think you can identify with?
I would be the big picture kind.
Okay.
But my family is going to want to know every detail that they can know. So it's okay with me if you give them whatever information that they want.
Okay, that's helpful. So when you came into the hospital, you had some nausea and vomiting, and we started some medicine for that. We did a CAT scan late last night, and I'm sorry to say that it looks like the cancer has spread. You've got some new lesions that are in your brain. You've also got some lesions in your liver and some new lesions in your bone that were not there on your last CAT scan a couple of months ago. So that shows that it looks like the cancer has spread from the last time we checked. I'm so sorry.
So that last chemotherapy didn't work.
It doesn't look like it. It looks like the cancer spread even through that. And I wish things were different.
I'm just trying to.
This is a lot to take in. Yeah.
It seemed like everything was going really well.
Mm-hmm.
And then all of a sudden, I just woke up and felt worse one day.
And, you know, when you came in and you had all that nausea, that can really be explained by the lesions in your brain. The new pain you were having in your abdomen is likely from the liver, the tumors in the liver. And that new back pain in your spine can be explained by what we saw on the CAT scan. And I'm so sorry. I wish I could come in here and give you some better news. I really wish things were different.
Chemotherapy just takes so much out of you.
Mm-hmm.
I was just hoping it's going to be hard on my family.
Yeah. What concerns you the most?
Well, they've just been such cheerleaders for me, and you know, they don't want to say anything negative or not hopeful, but they haven't wanted to talk about anything, you know, even conversations that we need to have, they haven't been able, they haven't been wanting to talk about any of that, and we need to, but do you think you could help me talk with them about all that?
Absolutely. We'll talk to them together, okay? We're going to be with you to help you through this. When they come back this afternoon, we'll go over all of this with them and answer all their questions.
Okay, thank you.
Do you have any questions about what I told you about the results?
Well, I can't think of any right now, but I wish I could. Can I see the CT scan?
Sure, I'll be happy to do that. When we come back this afternoon, I'll bring the CAT scan and we'll all look at it together.
Okay. Well, what do we do next?
Okay, so the next step is to try to get all the specialists involved to figure out a plan of care for you. So what we're going to do is get the oncologist to come and see you and review your scans, get the radiation oncologist to come and especially look at the lesions in your brain to see if some palliative radiation might be appropriate. And we're also going to get the palliative care specialist to come by and just talk to you. Because I think you're going to need information from all of those different groups and listen to possible treatment options, benefits, and burdens of those things so you can make the best decision for you. You and your family are going to be making a lot of decisions in the next few days, and I think part of my job is to make sure you have all the information you need to make those decisions. The other thing we're going to do is really aggressively treat your symptoms, so making sure we get your nausea and your pain under really good control so you can start feeling a little bit better, because I know you have not been feeling very well.
Mm-hmm.
So we're going to be working on those things. But I want you to know that we're here for you, and we're going to walk with you along the way. We'll be happy to support your family as well.
Thank you, Dr. Aaron.
Welcome. So, I just want to summarize so I can make sure we didn't leave anything out. We talked about your CAT scan results that showed that your cancer has spread. We are going to get all the specialists involved to figure out a good plan of care for you, and we're going to get your symptoms under really good control. And we're going to support you along the way. Okay. Do you have any questions, or do you need anything?
I need some pain medication.
Okay. We can get you some pain medicine. So on my way out, I'll ask the nurse to come and bring you some medicine. And then this afternoon, we'll be back about mid-afternoon, and we'll visit with your family. And I'll bring the CAT scan to take a look at, and we'll just take it from there.
Okay. Thank you.
This video just showed the steps of the SPIKES protocol. Usually these conversations take longer than 5 or 10 minutes. There are various ways to express empathy to patients and families, nonverbal ways and verbal ways. Oftentimes in these difficult conversations, we just don't know what to say. So in the next couple of slides, I'd like to give a few practical tips on how to effectively express empathy. Helpful tips include active listening, using the ask, tell, ask method. Finally, we'll talk about some helpful phrases to use. Active listening. This is essentially listening without interrupting the patient or the family. This takes time. These are not conversations that you can rush through. Patients and families will know when you are feeling rushed by the tone of your voice and by your body language. So I would advise that you make sure you have plenty of time to spend during these conversations. Having some therapeutic silence can also be very helpful in these conversations, letting the family and patient process what you've just told them. My best advice to incoming house staff is to make time to practice these communication skills, to be proactive in finding time to spend with patients and families. Using active listening is essential for picking up cues and nuances in these difficult conversations. Using the ask, tell, ask method. This is a very powerful tool for having these difficult conversations. Elicit the other person's perspective before starting your conversation. And we do this in the spikes method with the P and the I, asking the patient what they know, asking the patient what they want to know. It really helps frame our responses. So again, asking the patient what they know, what they want to know, then telling them what the bad news is, and then asking for questions. This method works so much better than the tell, ask, tell method, which is what most physicians tend to do. We go in and we tell the patient the bad news, we ask for questions, and we tell them what the next step is. That usually doesn't work very well. I would highly encourage you to use the ask, tell, ask method during these conversations. Now we're going to talk about helpful phrases to use during these difficult conversations. My advice is to write these down and remember them. I wish things were different. Tell me more. We're also going to talk about some phrases to use to help patients set goals and to help patients and families reframe a difficult situation. I wish things were different. This is a very useful phrase in difficult conversations instead of I'm sorry. This helps promote alignment over hierarchy. It avoids a sense of error or blame, and it allows for hope and realism at the same time. And this is a good expression of empathy. This may be helpful for patients and families who may have unrealistic hopes, disappointment in the limits of medicine, are experiencing grief, or after you've delivered bad news. Tell me more. This is the E in explore, so tell me more. Tell me more about why you're concerned. Tell me more about why you think that way. This is a very helpful phrase, and I usually use this when I need better understanding of what someone means. It allows for deeper exploration, and it's not condescending or offensive. Focusing on goals. After you've broken bad news, the next step is really to help the patient clarify their goals of care. Some helpful questions are, what are your hopes or fears for the future? What concerns you most about your illness? How is your treatment going for you and your family? As you approach the future, what is most important to you? These are helpful questions in eliciting goals. It's hard to come up with a plan of care for a patient if you don't know what their goals are. Reframing. It's okay to keep talking about hope. Hope is not something that physicians can just give and take away. Hope changes over time. So saying things like, let's focus on what we can do to help you, describing what you will be doing for the patient instead of what you can't do. It's important to reframe hope from cure to goals, from living longer to living better, especially when you're talking to a patient who doesn't have long to live or who has a terminal illness. We don't ever want to say the phrase withdrawing care. We never withdraw care from patients. We can always offer pain and symptom management and help patients achieve a good quality of life. So some phrases to avoid. Do not say, what do you want us to do? Many times physicians will lay out a wide variety of options and then put all of the burden on patients and families to decide what to do. What you should offer are a few reasonable options, weighing out benefits and burdens of those options, and making a recommendation. Oftentimes when patients and families feel very burdened with too many choices that may not be reasonable, these conversations do not go well. Do not say withdrawal of care. We never withdraw care from a patient. We can always offer pain and symptom management, help patients with a good quality of life. We do not withdraw care. Do not say, stop the machines or pull the plug. Physicians can say we're going to stop the ventilator or we're going to withdraw life support. But phrases like pull the plug are very unprofessional. Do not say there's nothing more we can do. You should take that phrase out of your vocabulary. We can always do something for patients, be it pain and symptom management and helping with good quality of life. Do not say, do you want us to do everything? Medicine is complex. Diseases are complex. And we can't describe a plan of care in such dichotomous terms as do nothing or do everything. We need to talk to patients and families about benefits and burdens of treatment options in the context of their illness, their prognosis, and their goals of care. You are fortunate to practice in a medical center with great interdisciplinary resources. These conversations are very difficult, but there are many people around you that can help. Utilize your multidisciplinary team. You have social workers, case coordinators, physical therapy, respiratory therapy, nurses. You have a whole team that's helping you take care of this patient. Utilize your team members effectively. We have a wonderful pastoral care program at UAMS. There is a chaplain on call 24/7. They can be very helpful in providing an extra layer of support for the patient and family. Behavioral medicine. These are PhD psychologists who can come and talk to patients and families in these difficult situations. Ethics consultation. We have an ethics consult team who can also help in these difficult situations. We also have a very good palliative care team at UAMS who can help with these difficult conversations and be an extra layer of support for the primary team. In conclusion, work to improve your communication skills during your training. Practice and seek feedback. Use an organized approach when breaking bad news. Think about the steps in the spike protocol. And remember to utilize your resources around you. If you have any questions, feel free to contact a member of the palliative care team. Thank you for your time, and good luck in this coming year.